Thank you very much, esteemed Yuri, for your presentation, for your talk. I believe that today, during the day, as a co-host, you will have multiple opportunities to provide your contribution to the most relevant points in this topic, on this topic. CRT, resynchronizing therapy. Unfortunately, we're supposed to move on. We simply don't have the time for this for this slot. No time for the Q&A session. Just one kind reminder for the presenters. We have some time for the presentation and 5 minutes for the Q&A afterwards. Right now, I would like to bring up a video of the second webinar. Colleagues, the movie, please. Spinal cord neurostimulation. Thank you very much indeed for your attention. Indeed, neuromodulation, the most relevant matter of spinal cord neurostimulation, was the second webinar's highlight topic. The link below, please follow it to refresh your memory of this worthwhile webinar. At this point, esteemed colleagues, it is my huge pleasure to introduce Professor Luca Santini, Cardiovascular Division, Grassi Hospital, Roma, Italia. So, Luca,
hello, Andrei,
has been our good friend for many years now.
Yeah, thank you, and I am really happy to be among you, many friends, and really it's an honor for me to be part of this important meeting and to have the chance to say hello to all of you, and Professor Karpenko, and you, Andrei, and everybody. So thank you for the kind invitation. And thanks to Yuri for the wonderful translation job he's doing, really excellent.
Luca, could you please bring up your slides?
Yeah, of course. Thank you. So when you want, I can start.
Please start.
All right. So sorry for this technical inconvenience. And we have just heard how many progress we have done for the therapy of heart failure from Professor Karpenko. But it's not only a matter to give a therapy, we should also follow up our patients in order to assess that we are providing an improvement in their clinical status. And actually, in the last years, we have had a very dramatic improvements in terms of following up our patients. And as you know, heart failure is really a huge issue worldwide, affecting almost 26 million people. And we also know that it's affected by a very high mortality, which is up to 50% in 5 years. And many of these patients, moreover, are dying for sudden cardiac death, up to 7% of them. But the main problem maybe is the very high rate of rehospitalization, which may be also up to 44% in 1 year follow-up after discharge. And this means that we also have an economical issue, because so many hospitalization affects dramatically the budgets worldwide, and so expenses for heart failure care are really very high, and these numbers are going to increase due to progressive aging of our population. So what are the goals of heart failure management? We should reduce mortality. We should prevent hospital admission, which are so crucial, we have seen. And we should also take care of improve the clinical status and the quality of life of our patient. And in order to achieve these targets, we have many weapons in our pockets. We should go through an uptitration and an updated optimal medical therapy. We should insist and really be pushing our patient to have a correct lifestyle and diet, exercise, and so on. But we should also make and perform a routine and very strict monitoring and follow-up. And finally, we also have the huge help from the device therapy, which was really important in the last 20 years. If you can look at this slide with all the pipeline of the progress in terms of the heart failure therapy, you can see that the cornerstone for the therapy was maybe the last important cornerstone was the 2005, when the CRT therapy became a gold standard for the treatment of these patients. And actually, now there is also a lot of progress in terms of pharmacological research. And we know that device therapy was very effective in prevention sudden cardiac death, thanks to the ICD, that we can affect the symptoms and to reduce the morbidity and mortality thanks to the CRT. But we also we need now to implement the pharmacological therapy. And for example, if you see that the CRT provided a reduction of 36% in all-cause mortality in our patient with a reduced ejection fraction, we also can see that the sacubitril valsartan, which is one of the last drugs which have been proposed and implemented in the guidelines for the heart failure treatment, provide an adding value of reduction in terms of all-cause mortality of 38%. So we are really focusing on a lot of news in terms of treating our patient. But there are also many other promising drugs which are under study now. And sometimes it's also a matter of luck, and there is a sort of serendipity-based medicine. A typical example is about the gliflozin. You know, gliflozin are born as drugs for the diabetes. They are able to inhibit the SGL transporter receptor, and in many trials at the beginning, they were found to be very effective also in treating the heart failure patients. The last trial, the Emperor trial, showed incredible results in terms of hard endpoint, reducing the cardiovascular death and hospitalization for heart failure. And very soon, it's already in the guidelines for patient with diabetes and heart failure, but very soon I believe that the European Association will include this family of drugs also for the treatment of heart failure patients without diabetes. So it's one of these important points in the history of medicine where you are looking for something and you find something different that is surprising you. So if you look at this flow, it's the typical flow of an heart failure patient, which have at the beginning plateau phases where the sickness is stable, but then dramatically we face with very fast and frequent acute decompensation. And if we want to change and to flat this curve, the only way is to provide to our patient a very strict follow-up in order to prevent acute decompensation events, which are the main issue we are dealing with in treating our heart failure patients. But the only way to do that, to achieve this target, is to make a lot of resource, to use a lot of resource. And this is not very easy, especially in this moment where we are facing with a dramatic mismatch between the healthcare workforce and increase of the chronic global disease burden. So we need a help also because the taxonomy of disease is changing. We are not going to analyze the cardiovascular pathologies only as a static condition, but they are more and more dynamic and highly dimensional. We need to take into account imaging data, biochemical data, clinical data. So we need really a huge effort to be effective in treating this patient. We need our help. I was saying that is also a revolution, and which is called e-health, because alone we are not able to get it. We know that now we can record every single clinical parameter. There are plenty and thousands of different sensors, and majority of them are already wearables and will be invisible very soon. Everything that can be digitalized will be digitalized. And if you ask me what about what is not going to be digitalized, I'm sure that very soon we will be able to digitalize also this kind of data. Actually, as a cardiac pacing physician, we have already been a pioneer for telemedicine because we started at the beginning of 2000s using the remote monitoring of our implantable device. And since the beginning, we understood that the main issue of the remote monitoring was the ability to detect clinical events. The majority, almost 90% of the data we were collecting by our these implantable devices were clinical and not only related to the devices. So we shifted very soon from a simple remote device monitoring to a full and complete remote patient management. And as you know, now remote monitoring of our implantable device is a gold standard, is included in the guidelines as a class 1 indication. But if you see, this is especially true for patients with atrial fibrillation, while for patients with heart failure, we have just a class 2 indication in the guidelines. Why this difference in between these two, the twin pandemics of our age? Actually, because all the trials which were comparing a standard follow-up of our patient with implantable device with our remote monitoring of this device were disappointing or provided natural results, but in time, which was the only trial showing a reduction in mortality. And there are several reasons to explain these disappointing results. The first is the kind of data we were going to analyze. Second is the kind of technology we were using, which are not all the same. And finally, also the organizational model, which is a very key point to provide a correct and effective remote monitoring of our patients. As you can see, the first trial, they were all focusing on the detecting of the acute decompensation through the detecting of the thoracic impedance decrease. But focusing only on this single parameter provided a neutral or negative clinical outcome, while we know, as the guidelines tell us, that we should go through a multi-parameter monitoring based on ICD. That's the target, and that's a very clear example that can explain why. If you look at these two graphics, you will see that both of them are showing a decrease in thoracic impedance. So patient A and patient B, both are going through an acute heart failure event. Not at all. If we can look at the full picture, we can see that only the patient A is going through a true acute decompensation, because all the other parameters are coherent with the decrease of the thoracic impedance, while on the patient B, that was the only data, while the others were stable. So maybe this was an artifact or a confounding data, which is very common in our experience, focusing only on the thoracic impedance decrease. So this is just to tell that we should have a complete picture of our the clinical study of our patients. So we need to collect contemporaneously many data, but we are able to collect data, but this doesn't mean that we are able to use them, because it's very complex to put together all this information to have a final information which is also useful for us and for our patient. And we need an help again, because we are not able to implement and to integrate all this information in a very quick way. So we need the help of artificial intelligence, which are really a breakthrough in our clinical practice, and they will be more and more in the next future. Machine learning are really, I believe, the base for the new technologies in terms of follow-up for this chronic disease. And we have an example of this applied in the clinical practice thanks to a new algorithm which is really very useful and promising, which is called ArtLogic, and which actually do exactly what we are used to do when we visit an heart failure patient in our office. What we do, we visit him listening to heart sounds. We see if there is an S3 tone, for example. We ask him if he breathes in correctly or if he has dyspnea, how many pillows he uses at night, if he can make effort without being dyspnoic, if he feels tired, if he is gaining weight. So all this clinical assessment evaluation we are used to do in an office, it's now possible to perform automatically by the device, which is able to record all this information and put together, is able to record the heart sounds, measuring the decrease of S1 and if there is an S3, of course, we can measure the thoracic impedance, the rate and the volume of respiration, the activity of the patient, the mean heart rate in the night. And so combining all these parameters in a simple index, we can have an alert which is able to advise us that the patient is moving fast through an acute decompensation. This is the ArtLogic, which has been studied in the MultiSense trial and not randomized and international trial, which provided a very high sensitivity of this algorithm, up to 70%, and which showed to be able to advise, to give an alert about an acute decompensation up to 34 days before the event finally occur. So really a huge help for us. And you can see that in the multivariate analysis, the ArtLogic in this MultiSense trial was the clinical variable which correlate much better with the clinical event compared to all the other factors, like including NT-proBNP, for instance. And this is a sub-analysis by Gardner, which is showing that this index is really strong in stratifying patients, because when patients are in out of alert state, they have a very, very low percentage of events per year. That means that we could dedicate our resource and our main efforts only to patients in alert status, and this is very important when we are dealing with a matter and an issue like the lack of adequate resource we can use. And another important issue is that ArtLogic showed to perform in stratifying our patient really great, even better than NT-proBNP. You can see that when we have a low NT-proBNP, but we are in ArtLogic alert status, we have a significant rate of events, while when we on the opposite, we are out of ArtLogic alert, even if we have a high NT-proBNP, the alerts are really low. And of course, when we have both the indicators, NT-proBNP high, and also we are in ArtLogic alert status, the rate of events is higher. So this was just the results of a trial, but we also now have experience from real-world data, because we have been in Europe. There are several centers, and we joined together, and we were the early adopters of this algorithm, and we performed first a retrospective phase and then an active phase. The retrospective phase was completely blinded, because we enabled the algorithm, and which is available on the remote monitoring platform, the Latitude platform of the Boston Scientific, and we were able to correlate this with all the clinical events which have been occurred in the previous months. And we were able to, for instance, to find that many of these, the clinical events that have occurred, could have been detected by the algorithm, which were giving and providing an alert every time that then the patient, before the patient went to the hospital. But this is just an example to show how it works. This was a patient, and you can see on the graphic that all this increasing in the curve, it's when we overcome the threshold, the art logic give us an alert, and every time the algorithm gave an alert, the patient actually a few days later was hospitalized for an acute decompensation event. So in a blinded pattern fashion, we could actually provide the utility and the efficacy of this algorithm. And we also confirmed the data from the multisense trial in terms of this incredible anticipation of the detection that was up to 38 days for the hospitalization. We could show that the majority of the alerts were correlated to a discontinuation or reduction of prescribed heart failure therapy. And this is a very important point, because this taught us that in many cases, the problem is that the patient, the adherence of the therapy to the therapy by the patient, which stop, for example, the diuretics or reduce the dosage, and so they undergo to an acute decompensation. We also confirm the importance of the heart sounds, which really are a very strong predictor of acute decompensation event, because in 100% of warnings, there was an involvement of the increase of S3 or decrease of S1. And so this is very important, because when we are looking at an alert which is triggered by the heart sounds, we are sure that there is an heart failure event. If we have not an heart sounds involvement, maybe we could also deal with a respiratory problem, and we could stratify our patient better. But we also showed in this other study that the heart sounds measurements provided by the algorithm was really effective and correlate very well with the echocardiographic measurements of the diastolic and systolic function. So again, assessing very importantly the efficacy and the ability of this algorithm to correlate with the physiology of our heart. But we went more forward, and we also studied, and we still are doing this algorithm in an active phase. That means that we are trying to understand how it can help us in the management of our patient. And this is just the first publication we got together with a multi-center group in Italy, where we were able to evaluate the number of alerts deemed clinically meaningful and the proportion of new clinical events which were signaled by the alerts, and the proportion of them which were actionable alerts. And we also compared a strategy of alert-based follow-up with a strategy of scheduled monthly remote transmission. And we could evaluate so the association between the alert condition and signs and symptoms of worsening heart failure. And we found again that the algorithm performed very well. Many of the events were correlated to symptoms or signs or clinical deterioration. Again, discontinuation or reduction of the prescribed heart failure therapy, or for example, decline and reduction of CRT percentage in biventricular defibrillator recipients. And also we could see that the action we could take following the alert, they were very effective, especially the diuretic dosage increase, because again, we found that many times the problem was the reduction of the interruption of the diuretic therapy. We could also undergo to cardioversion for new onset atrial fibrillation, or reprogramming of the device if we needed to optimize the CRT programming. So a really great help. And this is just an example. Again, you can see the red line is when the patient interrupt, in this case, the diuretic therapy. After a few days, the curve start to increase, overcame the threshold, and we had heart logic alert, which is the blue line. We were able, so remotely, to call the patient and to to increase the diuretic dosage again, and after that the curve started to decrease, and we finally reached a stability for this patient. So this is just an example to show how we can have a clinical true impact in our monitoring in our patients. And we also found in this experience that we don't need to schedule every month follow-up, remote follow-up for this patient. We can, it's so trustable that we can go to adoption of a heart logic alert-based management strategy. That means just follow the alert patient, and we can follow the patient that are in out alert status only maybe once per year. We don't need to follow up them more often because the alert performs so well that we can trust it. That's another important message in terms of organizational model. Of course, the final word will arrive from the randomized trial, which is under evaluation. It will be complete in the 2024, beginning 2025. The first phase is the not randomized, which is very similar to our first experience, but the most important in the phase 2, which will be randomized, comparing the remote patient management using heart-logic alerts to drive heart failure care compared to standard remote patient management without heart-logic alerts. Also, other companies are fastly moving to implement in their device and remote monitoring platforms such algorithms, and there are already some first experiences. So this means that in the future, this kind of monitoring our patient will be really the standard. And what we learn from this first experience is also that when we talk about heart failure patients, when the patients say, I feel healthy, it doesn't mean that is really healthy, because we should we should give our intervention when before that there is a clinical significant deterioration, and this is a matter of time, and this is not very easy because, as you can read, both patient and physician dealing with heart failure have a propensity to underestimate when they are stable. When the patient is stable, maybe in NIA class 1 or 2, we are prone to think that everything is going fine and we don't need to implement or to update our therapy, for example. And this is not true, because when the perception is misleading when we are in a class 2 NIA phase, of course, because yes, we have not so many symptoms, but still the structural disease is moving fast. We have the remodeling of the heart. And so this is the moment where we should give the patient the best therapy we can. And this is not very common, because there is this trend to be scared of the potential side effects of optimized complete drug therapy. Sometimes we are not going to neither give the electrical therapy when, despite it could be indicated, because the patient is in NIA class 2, and we wait maybe that is going to a class NIA 3. So we should be more earlier in giving the best therapy we can to our patient, because also in the beginning of the heart failure stage, we have already electrical instability, and there is a progression, continuous progression of the disease. And if we compare the American Heart Association classification of the heart failure, which is taking into account the structural alteration, with the clinical classification, the New York Heart Association class, we can see that we are in class 1, for example. We already have a structural heart disease. Also, if we have no signs or symptoms of heart failure. So already here, we should start to give the higher and more aggressive therapy to our patient. This is the only way to avoid progression to the further stage. And we, as you know, let's hope that now it's over, but we went through a really dramatic crisis with the last pandemic. And this was also an opportunity from another point of view to implement finally the telemedicine and telemonitoring for our patients. All the main scientific association suggested and provided documents suggesting to implement the remote monitoring of patient with implantable device in the clinical practice. And this was, of course, pushed by the crisis of the pandemic, but is something that really it was not homogeneous worldwide, but now it should be and become finally, definitely, the gold standard. It's a huge challenge because, as you have seen, to monitor all these patients remotely doesn't mean that we have less work. Maybe sometimes it means that if we have even much more work, but it's also a huge opportunity. And moreover, in the future, when we'll be able to have many other data to collect. For example, finally, we will have also hemodynamic status evaluation, for example, with CardioMEMS. We will have the ability very soon to have also the chance to remotely detect some problem by blood test data or many other different information. So we need to analyze all this huge amount and volume of data, but we need to do this very quickly with a very fast way. And this is a really big challenge. And there are now artificial intelligence, as I said before, that really are fasting and very quickly implementing in our clinical practice. There are some apps, some of the algorithms which are able to detect, for example, an heart failure decompensation status only through the analysis of voice. There are many other examples that are really at the beginning of a new era. And maybe this is science fiction, maybe not, I don't know, but it's foreseen that in few years to help us and our neural ability to analyze very fast all this information, we will are going to send nanorobots into the brain via capillaries, which will provide a full implementation and immersion in virtual reality with our nervous system. So I don't know if this is true, but it's not so far from the reality, in my opinion. And finally, this is very amazing and fascinating, but we should never forget that we can use all the technology we want, but we should always follow our clinical judgment, which is the polar star for our profession. So this way to put all the information in a linear, logical, and sequential thinking, which is the base for our for being doctors, true doctors. Otherwise, we will make the end of Charlie Chaplin in modern times, where he is completely fed by the machine and is not able to do anything else that open his mouth. Thank you for your attention.
Thank you very much. Grazie mille, dear Luca, for your wonderful presentation. Great talk indeed. Dear colleagues, whoever wishes to join me in the studio, please, now would be the time to ask the questions to Professor Santini and Raeni. Tech people, can we please bring up the screens? Yes, Luca is right there. Огромное спасибо, Luca. Thank you very much for the talk. Okay, so what are the questions, dear colleagues? Are there any questions? If I may, yes. Yes, of course, Yuri. Okay. Thank you for the amazing talk, amazing overview indeed. From the viewpoint of practical medicine, I knew that there were cutaneous impedance measurements, right, to detect worsening of HF. These are more less advanced, less sophisticated devices that don't have to be implanted. So cutaneous devices, what is your opinion, dear Luca? The worsening of HF diagnosing by skin impedance.
That's a good question, because we can share the heart failure population between those which have already implantable device, but this is just the top of the iceberg, and there are many other patients which are not implantable devices, and they are not going to implant them. And there is a telemedicine also for them, which is very fasting approaching in the clinical practice. And as you say, there are many sensors, cutaneous sensors, which are able, and they, of course, we need to try to have experience to establish if they really works. But I believe, I agree with you that this will be the future. And in the next future, maybe we also through the loop recorder, many of them will be able to be enabled with these algorithms. For example, heart logic and the heart sounds detection, it will be for surely available also on the new loop recorder, because the S3 and S1 detection is performed by the generator through the accelerometers, not by the lead. So we don't need the lead to achieve this information. And that means that also just with the cutaneous device, we can have all the same information.
Thank you. Thank you. Any further questions, colleagues?
Luca, скажите, пожалуйста.
Luca, one from me. Could you please tell me, what do you think? In which year, actually, what is the year when we will change the profile of our day-to-day operation? We will go completely remote. We will be able to put our trust completely into robots and big data. So your take on this?
Dear Andre, I can't see in the glass bowl, of course, in the future. I can just have the same perception you have, that day by day, every day, we have a new way to use this technology. And collecting data is more and more important, but also we should learn the proper way to use this information. For example, let's talk about the opportunistic diagnosis of atrial fibrillation. Now, just with an Apple Watch or whatever, we can detect many often an asymptomatic atrial fibrillation. But once we know that there is an episode of atrial fibrillation, it doesn't mean that we already know how to treat this patient. Should we give him anticoagulation? Shouldn't we not give him? So it's not only a matter to collect data. What we need again to do is to have specific flowcharts and information to how to use this data. Otherwise, we can just collect many different kind of information. There are now tattoos which are able to give glycemic level day by day or whatever. And this is something that in the market, it's also a matter of a marketing issue, of course, that the company are pushing a lot with these new and incredible devices. But doesn't mean that all of them are reliable and that will have a clinical impact. Many of them will finally be only gadget. So the main critical point is always to have a severe and strict protocol to assess the utility of these algorithms. We need the demonstration by trial, by scientific approach, correct scientific approach before implement this new technology in the clinical practice. But in the future, I think you are right, maybe not robot, but a cooperation with artificial intelligence and machine learning will be mandatory, and it will help to improve our clinical practice very much. But I believe that maybe this will become a real true, not so far, but not before 10 years.
Luca, thank you. In this regard, could you please tell us, so all of us understand how limited we are in, say, training of doctors, in challenges with training, postgraduate training of doctors. There are challenges in medicine, in particularly in intervention cardiology, in surgery. So if we're putting up a barrier, say a decade, right, a decade from now, as an obvious one, as an apparent one, for the new changes to bring to come into life, and at the same time, would not envisage any fundamental changes. We do not envisage any fundamental changes in the curriculum, in the training of postgraduate training of doctors. So do you see a discrepancy there? Is that going to be a colossal barrier? Or first of all, we should be thinking about changing the curricula first, the postgraduate curricula. And then only secondly, or secondary to that, that step, once we've improved the training, it will help us get to the new prospects, new horizons. Is my question clear?
I believe so, yes, and I agree with you. This is a open point, but we can see, for example, I think it's experience of all of us when we work in the hospital. There are a huge gap between the different generation. Just for example, with the clinical documents, you can see the youngers, which are much more prone to record everything digital and to collect the information. But while on the other side, the older generation are really still love to writing by hand in the documents and so on. So this is just a stupid example, but you are right. We need to also prepare the young physician from the beginning to this new technology, disruptment, which will be in the next future. We need to be digital. We already are digital in our daily life for social, for communicating, and this is what we are doing now. Is the typical example. Who could think that 2 years ago, just 2 years ago, that we could make a meeting or a wonderful webinar like this remotely with people from Italy, Russia, Ukraine, all over the world. So that's the incredible speed of the future on technology. The real issue is that I'm scared that the speed of the technological evolution is overcoming the speed of human evolution. Every generation has something more, and this is, we know since the evolution theory of Darwin, but I'm scared that now the technological evolution is much faster than the ability of a human nature to adapt to this technology, and this push us and give us a lot of stress. And maybe this is one of the issues and the difficulties that we are living in these times. I don't know if it's clear, but this is the challenge we have to win. And artificial intelligence and digital world, it should be a help for this, not create more problems. That's the way, the rule that we should always follow. And to do that, we need, as you said, to start since the beginning. In the postgraduate phase, we should pay attention to the education about technological and the digital techniques. And it doesn't mean that we are not a physician anymore and become engineer, not at all. As I said, and the last slide of my presentation was focusing on the importance of clinical judgment. Nothing can replace this. So we should always have this polar star in our mind, very clear. But we need to use the technology. Otherwise, we won't be able to increase and to grow up in our clinical practice.